So how does this all relate to race? Why is it so specific to us today, and so important for us today to focus in on within the African-American community, and as M-Power is expanding, we're going to be working more within the Hispanic-American community and many other communities, is because we know there is this huge phrase often used today, health disparity or difference in outcome based on race. And what are the facts around that? Well, I've tried to summarize it by giving us 10 simple facts. Fact number 1, myeloma is the most common blood cancer within African Americans. That incidence is growing. So we know that when you think of blood cancers, we typically think of 3. There's leukemia, lymphoma, and myeloma. They're all somewhat related, they're kind of cousins, but more often than not, within the general population, leukemia and forms of lymphoma are more common. But within the African American population, it is the most common, and that incidence is growing partly as as the number of African Americans, proportionally speaking, in the country grows. So right now, approximately 13 to 14% of the country would be African American, and as I'll show you in a moment, approximately 20% of all myeloma patients are African American. That number is continuing to grow. On the other side, there are numbers that are smaller that we're working towards, as I'll share with you later today. For example, if roughly 14% of all individuals in this country are African American, only 6% of physicians in this country are of African descent. And that's something that we're working obviously to correct so that we can have a better representation even within the healthcare sphere. So as I've mentioned a couple of times today, myeloma is twice as common in African Americans. That's fact number 2. Fact number 3, and this ties into when the diagnosis is made. You know, when we went to medical school, we were sort of told, and I'm sure Dr. Cole and Dr. Zonder can back me up on this, we're kind of told that myeloma you think of as sort of a real geriatric disease, mostly when people are over the age of 70. The average age of diagnosis is around 69 to 70, but in fact it's significantly younger in African American and Hispanic American patients. And so sometimes people don't think of it in their younger patients. And I mean very young, as we heard from Yelek on in his 25th year. I traveled once to Latin America, to Uruguay, to meet what we think is probably the youngest person ever diagnosed with myeloma, was an 8-year-old boy. That's not very common, of course, to happen at that age, but it can be diagnosed at a younger age. As I commented that already, that African Americans comprise about 20% or 1 in 5 myeloma patients in this country. This is a little bit hard to follow, I apologize for this, but these are numbers that come directly from a big database, what's called the SEER database, where we just look at what is the expected survival or the expected death, sadly, the mortality of different groups based on their race and their diagnosis. So these are myeloma patients, and so we look at myeloma patients and what their expected survival are if you are Black, and if you are non-Hispanic Black. And so the difference here is twice. I tried to circle the number to show you a little bit here, 8 versus 4. So the time from diagnosis to death is half in African Americans than what we see in others. That's the part that is perhaps the most striking today and the most disturbing, and why we're doing what we're doing. I commented that part of that reason is, if I really had to break it down, I would say that there are, of course, critical overarching drivers of the disparity that you're going to hear a bit about today. Whether it's systemic racism, the social determinants of health, the healthcare system in general. There are lots of layers that have led to mistrust within healthcare in general. But specific to myeloma is the delay in diagnosis and access to the right treatments. And so the delay in diagnosis, remember I said, the average patient, it takes 3 visits to the family doctor before it's pieced together. It often takes about 6 months. Obviously, those are just averages. Some people it's 6 weeks, some people it's 2 years. The average is about 6 months. It's delayed in African Americans for lots of reasons. A lot of it is getting access just to primary care. You're going to be hearing from Donna in a few minutes about the importance of connecting with your primary care team and expressing your concern, and potentially even expressing your higher risk of diseases like multiple myeloma. The primary care providers themselves may not be as familiar with myeloma or realize that this 52-year-old black man may be at higher risk of myeloma. And maybe that anemia it isn't something that we just have to wait and watch. Maybe it's something we need to investigate further. Or the presence of confounding diseases like diabetes, which is more common within the African-American and Hispanic communities. How many of our patients have said to us, you know, for months my doc told me that my anemia, that the protein in my urine, that my kidney function, that my neuropathy, that was all from my diabetes. When in fact the whole time they were growing myeloma. Again, I'm not here to scare anybody with diabetes to go run to your doctor and say, do I have myeloma? But these things can coexist, and it's really important for us to make that distinction. Number 7 is that I sometimes talk about the 4 T's. These are the first 3. That if I were to summarize why I shared with you earlier that we've gone from an average survival of 1 year to over 10 years, it would be the result of 4 things that start with the letter T. Helps me remember them. Number 1 is triplets, or 3 drug combinations. Now we're about to change this because, as Jeff is going to show you, we're about to move to 4 drug combinations, right? Now it's very American, right? If 3 is good, 4 is better, right? Let's give them more, right? But nonetheless, the concept of using multiple drugs together. I mean, how have we, to some degree, overcome HIV? Not because we found one magic drug. It's because we use the right combination of drugs together. Myeloma is like that. And so we've used triplets. We've also used transplants, or autologous stem cell transplants. You're going to hear the basics of that also from Dr. Zonder in a minute, where we can actually give people a large dose of chemotherapy to wipe out their myeloma, but we rescue their bone marrow by having other, what we call stem cells, or seeds that can grow a new bone marrow. And then very recently, as Jeff also will share with you, this concept of CAR T-cell therapy, where I can take T cells out of a patient, or cells that are like soldier cells, train them to recognize the myeloma, multiply them in the lab, and then give them back to patients. Really remarkable. The sad reality today, however, is that African American patients and Hispanic American patients have had less access to those 3 things. I was just this week working with a team that had demonstrated, looking at all the CAR T-cell trials that have been done in myeloma as well as lymphoma leukemia. 1% of participants in those trials have been African American. So clearly under what we need to have. And that brings us to point number 8, which is the last T, which is clinical trials. And we're here to talk a little bit, and we will be talking with our patients today a little bit about clinical trials. And I know sometimes that sounds scary, and people wonder, am I going to get a placebo? Am I really going to get a real drug? And we're going to try and demystify that for you, because clinical trials have an immediate benefit to patients very often, and indeed can have a long-term benefit across the community. But clinical trials have moved the needle forward for us. And sadly, despite what I shared with you, that 20% of myeloma patients are African American, representation on clinical trials has been typically actually under 5%. This is about the most generous I could give it, at 8%. And when we look at what we call pivotal trials, those trials that have led to drug approvals, it's been more in the range of 2 to 4%. There are some biological differences. You know, someone from either a scientific or a public health background might say to me, well, you know, Joe, maybe African Americans have a shorter lifespan with myeloma because maybe they get a more aggressive type of myeloma. And in some diseases we may see this, in prostate cancer and others. But you know what? The opposite is true in myeloma. Sometimes we divide myeloma into 2 simple buckets, high risk and standard risk. African American patients are less likely to be high risk. They're actually more likely to be standard risk. And that's because of some of the genetic things that are listed here on the screen. But even if you don't bother with the genetic phenomenon, just that you would anticipate that African American patients would actually have a better survival because they're less likely to have the high risk form. Which brings me to the last point, which is that when African Americans receive equal access to care, their survival outcomes are equal and at times even better. And we've learned this through the VA system. I gave a talk this week to a series of physicians within the VA system, and we explored this concept. So in the VA system, at least theoretically, independent of your race or background, you're given the same access to diagnostics and treatment. And so when they looked at their database over the last 20 years, they found that black patients actually had a better survival than white patients with myeloma. So to me, this even widens the disparity more, because it tells me that they should be doing better, we should be doing better, when in fact we're doing half as well. And so that to me deepens the disparity. Next slide. So my last couple of slides is, well, what do we do about this? And surely, despite the energy in this room, we can't fix this in 1/2 day, but there's a lot that we can do. And it's going to take everybody coming together. And this is why we created the M-Power program, was to help facilitate the dialogue between all these groups, the lay community, the medical community, the regulatory community, the corporate community. We need to all work together to make this happen. And I believe one of the major missing pieces in efforts that have gone on in this sphere is to truly engage the community. It's one of the things that so impressed me about what they do at Carmanos, is that sometimes there's this idea that, like, here we are as the medical system, and you come to me when you need me, right? I'm not going to go help you until you come to me, right? It's like going to, my wife thinks I have an addiction to Costco. Anybody else go to Costco Anonymous here, right? So she's like, are you finding another reason to go to Costco, honey? I'm like, oh, but we really need 48 rolls of toilet paper. And so again, I'm not trying to pick on Costco, but like, Costco doesn't really reach out to me. Or maybe they send me, because I look at the app every once in a while, they send me notices, but really, I go to Costco to get benefit, as it were. But we need to understand, as health institutions, we actually need to reach out to the community to promote good health. And what better place to do that than in a church, where there is confidence and trust and support among its membership. And so that area of community engagement is what we're focused on here today, as I'll share with you in a moment. We're all together. And so if I had to summarize, if I were only allowed to show you one slide today, it would be this one. And it's pretty much my last one. And thankfully, you don't have to listen to me much longer. But I summarize empower with these 3 verbs that are in these 3 circles: engage, educate, and enhance. We want to engage the community in events like this, where people who have never heard about myeloma can understand the basics, can know how important it is, as Donna's going to share with us, about communicating with their healthcare team, that maybe they have some of these signs and symptoms and they need to talk to somebody about it. Maybe they know someone with myeloma that they can be a support to. All that aspect lands under engage, and we'll partner with anybody. We've partnered marvelously today with Carmanos and with this beautiful church. But we've worked with fraternities, sororities, the Black Nurses Association, the National Medical Association, barber shops, salons, you name it. We want to get the word out. Number 2 is educate, where we want to educate primary care doctors so that time to diagnosis gets faster. So there isn't that delay, so that they can know, when is this diabetes and when is this myeloma? What are the right tests I need to order? How do I make sure that happens quickly? Because time is of the essence in myeloma. And then lastly, what I'm going to conclude with in these last couple of slides is enhance, which is we want to enhance the care of those people who have myeloma through the providers that they see, through the nurses, through the pharmacists, through all the members of the healthcare team, and indeed the physicians, and find ways to do that. And so Empower is really a national movement. As I mentioned, we try to go from city to city and try to be emphatic. We don't just descend on Detroit and say, here we are, and then leave tomorrow. Our plan is to have an existing presence, to continually work with Carmanos and the community to try and engage. And we've done that in these other cities that I've mentioned. Next slide. We've also always had the premise of putting the individual in the middle and surrounding them. And we've worked, as you can see here, with all these groups and many, many more to really try and provide them all the resources that they need. Next slide, please. Many of these resources we've created electronically. We want to make sure that they're very user-friendly, even from a cell phone, knowing a lot of people may not have a laptop and people may not even have a cell phone. We want to be very conscious of that digital divide and provide resources to people in person. And so we've done a whole series of things. If anyone here is a hip-hop fan, you may recognize some of the people. Thankfully, I didn't have to sing during this part of our program, but you may recognize Dougie Fresh there and some others that we've worked with. Next slide. As I mentioned quickly, we did a program at Riverside Church, as well as broadcast to Grace Baptist on the Juneteenth weekend to raise awareness. And we're working, as I mentioned, on the educate side with primary care physicians, teaching them the basics of myeloma so that they can make the diagnosis more effectively. Next slide, please. And then lastly, truly lastly, has been our work enhancing the care and Drs. Cole and Zonder, who will be presenting shortly, were participants in this. We created a program for medical students where we took minority medical students, many of them from historical black colleges and universities, and paired them with a myeloma expert for 6 months to do a project related to health disparities. And then we all came together, next slide, we all came together at the annual meeting of the National Medical Association, and all the students had an opportunity to present their poster. It was really a remarkable day because the director of the National Cancer Institute, so for us cancer geeks, this is like a really important person, Monica Bertagnoli, she was there, and she agreed to do the poster walk with me. And so these medical students, who 60% of them was the first time they had done any kind of research before, any kind of project before, got to present their work to the director of the National Cancer Institute. And our hope is to educate these students, no matter what they become. I mean, I'm hoping they become myeloma doctors, but no matter what they become, that they're sensitized to the importance of health equity and how this disease has affected their community and what they can do in service to support that community. I'm going to stop with a little video here that's only 55 seconds long, and so we'll let you get a glimpse in the M-Power program we had in Tampa just a few weeks ago. As with M-Power, our objective is to change the course of myeloma. No matter what your background, what your race or ethnicity is today, we're here together to fight against myeloma. That's going to take people like those who are in this room, people who are patients, people who are care partners, people from industry, people from the community, people from fraternities, sororities, churches, all the people we're trying to bring together to overcome this. As we think a bit together about why we're discussing all of these topics today and why we're thinking together about M-Power, is that as with many cancers, but arguably, as I noted, perhaps even more so with myeloma, race does matter in myeloma care and survival. And our objective is to change the course of myeloma